Thank you so much. Now we move forward with the last case presenter for the CD competition. And for this, may I request the presence of Dr. Anubrata Shane to please come up on stage and present his case. So this will be the last case presentation over here, and then we will be gradually moving on to the sessions that we have followed by live sessions. So there is so very much to explore today. So we are here, few sessions will be here, few session will be in the Victoria Hall. So it will be a combination and mixture of both. So now, Dr. Anubrata Shane.
Good morning to my teachers, my seniors and colleague. Myself, Dr. Anubrata Shane, resident of Arctics, presenting a case of IVL in left main coronary artery disease. So my patient, a 64-year male chain smoker, presented with worsening exertional angina of class 3, despite maximally tolerated anti-anginal therapy. He was a known case of COPD, hypertensive but non-diabetic. The echo revealed there was generalized wall hypokinesia with ejection fraction of 50% with good RV functions. His hemoglobin was 15.9 with a creat of 1.32. We did the angio and it revealed left main triple vessel disease. There was tubular left main disease with calcification and also disease in the LCX as well as diffuse disease in RCA. So this gave us the first option of CABG and we promptly did look for a Lima. But when we took shoot, it revealed there was stenosis in the subclavian as well as the Lima was diseased. And more so, the bilateral renal artery were stenosed and the peripheral arteries were also diseased. So we have only left with the options of PCI as he was a CABG turndown. So before starting, we had these queries in our mind, whether which vessel to do first, whether it is RCA or left main LAD and LCX, what to do about the calcific left main, what are our choices of plaque modification, whether it is ROTA or IVL, and in intravascular imaging, which we would prefer, IVAS or OCT. And as we were doing unprotected left main, if need of mechanical circulatory support, which will be our choice, IFBP, ECMO or Impella. So we went with RCA first as we wanted to establish the flow in the right system to support the left system and beginning of the intervention in the unprotected left main. The RCA was also a very much diseased, calcific, and it was tortuous. We required meticulous predilation, bed preparation with sequential non-compliant balloon dilatation, and we also needed catheter extension of Guidezilla as it was a tortuous artery and as well as calcific. So first we went with two drug-eluting stents of 2.75 into 24 and 3 into 32 in the mid and prox RCA. For stent deployment and stent delivery, we also required Guidezilla. And after stenting, we found out that there is a residual disease distal to the mid RCA stent, which was confirmed by IVAS, and it showed up fibrocalcific plaque. So we had to go for another stent distal to that of 2.75 with 18, and this was the final result of RCA, and which is confirmed by IVAS also, which shows a roundish RCA result with in both the diameters more than 3 luminal stent area. Then we proceeded for LAD and we did a pre-procedural IVAS and OCT run, which revealed severe medial calcification. There was also some luminal calcification and the arc was more than 270, which we can very well appreciate from the IVAS. And apart from that, in the middle one, there was a calcific nodule, which we can appreciate both from the IVAS as well as OCT. So here in a left main calcification, a large lumen with so much medial calcification, we choose IVL as the procedure because we had the rotor bars of 1.5, 1.75, which won't even touch the calcium. So we pre-dilated LED to LMC with non-compliant balloon. Then we did IVL to left main and also LED. And as there was occlusion for 10 seconds for 8 cycles, patient had episodic bradycardia as well as hypertension. And post IVL, we did a OCT run, which clearly showed cracks in the calcium, which can be appreciated here. This was one of the cracks here. Here also you can appreciate that, and this one in the nodule. But along with that, we have a problem as well. There was a aortosteal dissection here. Here there was a aortosteal dissection. And you can see this is the nodule and there is a clear crack in the nodule. Then we post-dilated it, modified it with another NC balloon, and this was the final result. And we deployed a 3.5 38 stent and post-dilated it, and this was the final OCT result with good left main area of 10.6. Sorry. And good minimal stent area. And the OCT clearly shows good apposition and stent expansion. So coming back to our questions, which one we address first? As I have mentioned, we addressed RCA first because we want to stabilize the patient, provide good hemodynamic support so that we can intervene the left main. And as I also said that we preferred IVL, and this algorithm also shows that we filled up the criteria for both for IVAS and OCT, that there was a more than 270 degree arc of calcium, a length of more than 5 millimeter. Here it was 12, and there was a definite calcium nodule visible. And this was also summarized here only, and we have filled all these 3 criteria. And is there any experience on that? There is a small study with 16 patients of left main calcium where they took IVL and they gained good luminal area in 100% of cases. And the outcome was good. And as far as the IVAS and OCT concerned, IVAS is always preferred in the left main because of the more lumen. OCT has a less depth perception. And also there was an ostium disease in the left main. For OCT, we need to disengage the catheter and also make sure that there is a good dye flush, which is difficult. For that, IVAS is always preferred. But as there was a calcium dominant, and we need to see the thickness of calcium, and also after IVL, we need to see whether there are cracks or not. OCT was also needed. We had the luxury of having IVAS in our lab, so we did both. And we had IABP ready in the lab with established line. Thankfully, we didn't require that. So this is what I need to say. There are multiple vascular territories, and it was involvement and surgical turndown case. We tried to achieve a complete revascularization. Meticulous planning and use of intravascular imaging was key to our success. The lumen is wider, difficult to rotablate, so it was an ideal case for IVL. And in order to maintain hemodynamics, we have taken breaks between giving the IVL burst, and we kept IBP ready in hand. Thank you.
Very challenging case, Ranubroto.
Thank you, sir.
But I'm equally worried about his other vascular territories. So how many months now into the follow-up? When have you done this?
1 month ago, sir.
1 month. So far, so good. What has happened to the kidney function?
Kidney function remained stable. It was initially 1.32. The kidney function is around about there only.
So IVAS OCT, you have yourself raised the question and answered it.
Yes, sir.
But you had the luxury of using both.
Yes, sir.
So you think you not using OCT would have given you an inferior result, or how has it helped you in the final?
Possibly not, but we wanted to see the calcium, the thickness, And the result of IVL we want to share, and we were expecting this to be academic case only. As we had the option of having both, we go for it to document it.
What happened to aorta ostial dissection?
Sir, we have stented it. We have overhang.
Not show us.
Yes, sir.
The last frame was showing the dissection.
You tell us about the left main stent you have used. What is its size?
Yes,
How
sir.
much it is protruding into the aorta?
Sir, here. We have overhang 3 to 4 studs outside.
Can you still see the dissection?
Yes, sir, here. And also here. There is the dissection.
How did you decide the size of the IVL balloon?
Yes, we went for 1:1.
What was the size of the left main?
3.5.
Left, what was the size of the left main?
Pre,
Used to be 4.5.
yes,
You took a 3.5 for left main.
yes, we went for 3.5.
This is not 1:1.
Yeah, the pre-run showed it was around about 4 in the left main. This is post, sir. And we inflated it to 4.
That used to be more than 4. Still,
No, sir.
3.5 is not. It's not 1:1.
So this is the thing. There we can see this was the close to the left main. It was on horizontal. It was looks like 3, and in vertical it is 3.5. Yes, sir. So lower one is LED and upper one is left main, sir.
You see the proximal LED, it's almost 4. 1, 2, 3, 4.
Yes, sir.
Proximal LED.
Yes,
Left
sir.
main must be more than 4.5.
But due to presence of calcium,
Because the
we
vessel, we are
Yeah.
discussing about the vessel size.
Yeah, yeah.
It's more than 4.5 approximately. And we are using a 3.5 balloon. So this is not 1:1.
yes, sir. Agreed. Yes, I agree, sir. And in IVL balloon, I have the options of 2.5 to 4.
It's a long legend. It's the distal. We usually measure the based on the distal diameter, the balloon. But if there's calcium in the proximal segment also, then sometimes we use a 2 balloon, one matching the distal size and one matching the proximal size.
Sir, we only looked for having IVL in the left main mainly with some LED ostium. We didn't go into the left LED too much. We had the option of 2.5 to 4. We take 3.5. We inflated it into 4. Gave the shock waves, then inflated to 6, so that after giving shock, we can produce the cracks.
What was the cause of dissection? IVL or?
IVL, sir, post IVL. Yes, sir. Thank you, sir.
Thank you so much. And I will thank the elite moderators and chairperson for moderating the CD competition. Thank you so much. Now we move on to the first session of the second day of EIIC-Con 2023. And for the first session, we have is pressing issues. For this particular session, may I request the presence of the following excellencies on stage. May I request the presence of Dr. P. Shahu to please come up and join on stage. May I request the presence of Dr. Pankaj Manuria to please come up on stage. May I request the presence of Dr. B.P. Pandey, sir, to please come up on stage. And I will extend my thankfulness to the elite dignitaries. Thank you so much. Thank you so much. And now we start off with the first session, pressing issues. I have just announced the chairperson name for this particular session. I will take the privilege of announcing it again. Dr. P. Shahu, Dr. Pankaj Manuria, and Dr. B.B. Pandey. So we will have them on stage right now. And to moderate this particular session, we will be having the presence of Dr. Kaushik Bandopadhyay, Dr. Shubhashish Chakraborty, and Dr. Arnob Banerjee. The first topic of this particular session will be by Dr. Shomo Patra, and his topic will be chip algorithm. So after the picture perfect frame of the day, we move forward with the first session of the day. So I will request all the dignitaries to please take your seats, and I will request Dr. Shomo Patra to please come up for the first topic of the day, that is the CHEAP algorithm.
All speakers are present. Somo Patra, I cannot see.
Promo Patra. Okay, so we move forward with the next topic. We will be having the presence of Dr. Sandeep Bansal to please come up on stage, and the topic he will be covering is viability algorithm. So the first topic of this particular session, pressing issues covered by Dr. Sandeep Bansal, viability algorithm.
Dr. Pradeep Bhaumik is not. Pure private. Yes. So the first speaker is Dr. Sandeep Bansal. This is a very pressing issue actually. Once we detect a three vessel disease, whether we'll do a PCI or we'll do a CABG, whether we'll do viability assessment, ischemia assessment or not, no better person than Sandeep to discuss this issue. And then we'll have a comparative session by another learned speaker, Dr. Soumitra Kumar. Sandeep, floor is yours.
Thank you, sir. This is a rather longish topic, so please allow me if I overshoot a little on time. We have ample time.
You have a luxury of extended time
Thank you
because
so much.
two speakers are not there.
Yes. So the first important thing to understand in this particular area is the difference between a stunned myocardium and a hibernating myocardium. So this cartoon shows that whenever there is a decreased perfusion in a particular area, there is also a reduction in function, the top of it. But when the ischemia is relieved and the perfusion is restored, the function of the myocardium continues to be low, despite the perfusion having been restored. And this entity, when you have a restored perfusion, but you continue to have a myocardial dysfunction, this is known as myocardial stunning. On the other hand, if you have a reduced perfusion and you continue to have reduced perfusion, the, the function of the ventricle continues to be hypofunctional. And this, myocardial dysfunction, or you can say the hypocontractility of myocardium, in the presence of a continued hypoperfusion, is called as hibernation, and that is going to be the major topic of discussion in my talk. So what is a viable myocardium? A viable myocardium is generally referred to as an alive myocardium, independent of its contractile status. So it is alive, although it is hypofunctional. This term is actually derived from hibernation, as we all know, is derived from amphibians. Whenever the winters come, the amphibians go deep into the water and they reduce their functioning to the extent that they are alive, but they are not moving around. It is also important to remember that all ischemic hearts, whenever we do any reversibility testing, we do a treadmill, we do a dobutamine stress echo, or we do a stress thallium test or a stress MPI test, we are actually detecting ischemia. So it is important to remember that all ischemic hearts are viable, but the contrary is not true. All viable segments are not ischemic. They may not show ischemia. It is also important to remember that in order to judge whether the myocardium is alive or not, it has to have some degree of preservation of wall thickness. It has to have a contractile reserve, as we understand, to have cellular membrane integrity and an active metabolism. The substrate changes, but the metabolism has to continue And this metabolism needs that there is some amount of, perfusion by the blood. It can be an antegrade blood flow, and many a times we find that there is 100% block, but the artery is getting perfused through ipsilateral or contralateral collaterals. So the existence of blood flow is also very important. Now, all this is theoretical. The main thing is, the main importance of viability is whether the functioning of heart is going to improve once the flow is normalized or not, once the flow is normalized. So as I said, the tests for viability take into account all these features that are highlighted in this particular slide. That is, there has to be some minimum amount of wall thickness of the myocardium. The myocardium, when stimulated, should be able to contract more than it is doing at the baseline, or what we call as contractile reserve. It has to have cellular integrity. You cannot have destroyed cell wall or the integrity of the cell destroyed and have a viable myocardium. And it has to continue to have metabolism. The substrate, however, changes. We need to understand that the normal substrate for a normal heart is free fatty acids. And when there is a continued hypoperfusion or low flow to the area, the substrate changes to glucose, because this is a more energy efficient pathway in those given scenarios. And so the metabolism has to change from free fatty acids to glucose. And as I said, the perfusion is a must. It is not that you can have no perfusion at all and have a viable myocardium. So based on that, this also shows the 4 major ways in which myocardial viability is detected. It can be detected. There are some non-invasive and other markers also, but by and large, we either use echocardiography, we use positron emission tomography, or the PET studies, as we call them. We also have thallium studies and technetium-based, perfusion studies. And in the center, as you see, is the CMR, or the cardiac magnetic resonance imaging. This is in the center because currently it is believed that the best resolution up to the tune of about 1 to 2 millimeter is actually given by magnetic resonance imaging. So this is also believed to be one important method of diagnosing a viable myocardium. The concept of viable myocardium is not very new. It is about 20 years old approximately. And this is one of the seminal editorials by a person who did a lot of work in this, Shahabuddin Rahimtullah. He actually showed in one patient who had an LAD disease and the ventricle that was dilated, which is shown on the left of the screen. After the CABG was done, there was a great improvement in the ejection fraction from 37% to 76%. And this was largely contributed to by a reduction in the left ventricular end systolic volume. So if somebody asks me what is the single most parameter that changes, it is actually the left ventricular systolic parameters. Now, this is based on the fact that he also observed that if you have a normal heart and you develop occlusion, in the acute stage itself, when you revascularize, the functioning normalizes. If the blockage continues over a period of time, you have remodeling. And if you revascularize the heart early in the remodeling, it normalizes. If you revascularize it at a relatively late time, there is a reversal of this remodeling, but it is to a lesser extent. And if you have it in an absolutely dilated ventricle, and I'll come to this concept later again, there is the benefit is actually questionable. So when do you use viability testing? Not in very young patients, not in people who have angina, not in people who have a normal left ventricular function, and not in people who have ischemia on, the routine testing like treadmill or dobutamine stress echo. But it is more useful in people with left ventricular dysfunction, in the people who are relatively older, who don't have any angina that is present, and on their angiography you find a chronic total occlusion. And the purposes of the viability imaging are basically to plan the revascularization strategy, to risk stratify the patients, because those who don't have a viable area, they fare much worse. Their prognosis is much worse as compared to those in whom there are viable areas. And also to plan the revascularization strategies, as Dr. Pandey just alluded to. And there are some situations like a low flow state with aortic stenosis, for example. So these are the situations in which viability imaging is used. Now, the indicators of viability, well, if a person has angina, you really don't have to do, it should be a true angina. There, that is the strongest marker of the fact that even if the ventricle is dilated, even if the ejection fraction is low, and there is hypoperfusion, if the patient is having angina, that is the strongest predictor of the fact that the myocardium is viable. There are other markers, easier markers, such as lack of Q waves in the ECG. Many a times we get a patient who has a proximal LAD disease, but there are no Q waves on the ECG. Likewise, there are studies to show that persistent T inversion after a myocardial infarction is another marker of viability. Further, if many a times when we send our patients for a MPI scan, the nuclear cardiologist sends the patient back saying that though there is hypoperfusion, because there is a preserved wall thickening, the ventricle is very much viable. From our knowledge of echocardiography, we know that a myocardial infarction on echo or a scar is defined as, number one, failure to thicken, or systolic thinning, or failure to thicken by more than 10%. Also important is the presence of a contractile reserve. Many a times we find left ventricular angiography is seldom done these days, but in the good old times, when I did my DM, left ventricular angiography was a part and parcel of doing the cardiac catheterization, even if it was coronary angiography. So one noted that if a hypocontractile area increased in contraction after production of an extrasystole, the post-extrasystolic accentuation was enough to tell you that this patient has a contractile reserve. Although now in the modern times, we have more modern methods. So on the thallium scans, if we have radionuclide uptake, which increases by more than 50%, if we have seen any nuclear scan on the right side of it, there is a bar chart which shows areas which are absolutely dark to those which are bright orange. So that is the sliding scale on which the perfusion changes. And if there is a greater than 50% increase in the radionuclide uptake, that again is a marker of viability. Likewise, as we shall see, if there is a mismatch of perfusion and glucose uptake on PET scan, that is again a very strong marker of viability. And if you have on dobutamine stress echo, particularly, if you have a new inducible increase in the contraction, that is again a predictor of myocardial viability, because it tells you that this patient has contractile reserve. And if there is no or minimal late gadolinium enhancement on the cardiac magnetic resonance imaging, then again, it is an indicator of viability. So this slide actually shows that what is the sensitivity, specificity, a positive predictive value of all the non-invasive tests of viability. And as we find, if you consider both sensitivity, specificity, positive predictive and negative predictive value, the gold standard is at the present time is FDG PET, although a tough competition is being given by the cardiac magnetic resonance imaging. So these are the various modalities on the left side. So you have nuclear imaging studies, which actually use perfusion, cell membrane integrity, and presence of intact mitochondria on, to judge whether the area is viable or not. And the PET scans actually use the change in metabolism as the indicator of viability. Echocardiography and dobutamine MRI, they use contractile reserve, and the plain MRI uses the presence of scar tissue as a predictor for viability. Now, as far as echocardiography is concerned, as I said, we have known that if the ventricular wall is excessively thinned out, the presence of a ventricular wall thickness of less than 6 millimeter is actually a very clear indicator that this is likely to be non-viable myocardium. And when we do dobutamine stress echo, these are the various types of responses that we can have. And so what we find is that if a patient has a biphasic response, which means that when you start the patient on low dose dobutamine stress echocardiography, the contractility improves, and later on at high dose or peak of the dobutamine stress echo, if the contraction decreases again, this is the strongest predictor of viability. And of course, you have different types of responses on dobutamine stress echo. Now, as far as the nuclear scintigraphy is concerned, as I said, the radionucleases, they need to get into the cell. And for that, you need the integrity of the cell wall. As far as the nuclear scans are concerned, most people do not use thallium scan any longer. The good old thallium used to behave as potassium. And we know that potassium is an intracellular ion. And so thallium would go into the cell, and that it can do only well when the cellular integrity is preserved and there is some degree of metabolism occurring. So based on the thallium scans, we could predict more reliably whether there is myocardial viability or not. And I said, if there is a 50% increase in the tracer activity or more than 50%, then this is the most important criteria to be used in SPECT imaging. So on the top are the agents which are used for SPECT imaging, which is mainly thallium or sestamibi. And for PET scan, we have perfusion imaging, for which people use ammonia or rubidium. And we have the metabolic imaging, for which we use fluorinated deoxyglucose. Now, the thallium scans divide the segments of the myocardium in pretty much the same way as we do on echocardiography. And two types of things are important. What is the defect severity? As I said, it should be a more than 50% change. And what is the defect size? Because those two factors determine whether the function is going to improve or not. So this is a typical nuclear scan picture that we see. The first one is normal, which is showing orange color in the entire thickness of the myocardium, both at stress and at rest. Sometimes such defects may be present both at both at rest and at stress. And these are large areas, non-specified vascular territory. These are basically attenuation artifacts. The attenuation artifacts are more importantly present in the diaphragmatic surface and the inferior wall of the myocardium. If the defect is fixed, that means at stress also there is no perfusion, and at rest also there is no reperfusion in that area. This is suggestive of a scar. And the most important for us is on the extreme right. If we see towards the apex, there is a blue area on stress, which fills up with the orange perfusion at rest. And this shows that there is ischemia, and this is going to be a viable myocardium. As far as the PET scans are concerned, as I said, for this consists of two imagings. One is the perfusion, which means the blood is going there or not. And the other is metabolism imaging. And as I said, in cases of chronic hypernation, the substrate changes from free fatty acid to glucose. And so this is a typical PET scan at the bottom. And it has been seen that almost 1 in 4 segments, which are actually classified as non-viable on a stress thallium scan or a stress MPI scan, are actually determined to be viable on a PET scan. This is a slide which I've taken from one of my presentations for the CSI. I was asked to show a case where nuclear imaging had been done. And this was a 45-year-old male who had an anterior wall MI. And this guy drove his car for 13 hours from the border of Chhattisgarh to all the way to Vijayawada in Andhra Pradesh. And his angiography was done. The angiographer found that LAD was 100% blocked. And however, he was one of those kind ones. He did not blindly go ahead and open it up at that time. He said that you should come later when we will do some tests. The patient landed up in Delhi. He was related to one of my colleagues. And so when he came to us, I got a FDG PET scan done. And as you see in the first picture on the left-hand side of the screen, there is a large blue area, which is the perfusion scan. So that is the technetium perfusion scan. The large blue area suggests that there is no or very little blood going in that area. And the middle one is the FDG or the perfusion scan, which shows that there is a good amount of uptake of glucose by the same blue area, which is showing on the perfusion scan, which means that the substrate of this particular area has changed from free fatty acid to glucose. And that is why this area is viable. And when you subtract the two images, on the extreme right, you see an orange area, which is the area of viability. And so I went ahead, I did the coronary angioplasty of this patient. And after 4 to 5 months, his ejection fraction had improved from 30% to 47%. And his left ventricular remodeling also occurred. There was almost a 5 millimeters decrease in the left ventricular systolic diameter. So if we try to know the pros and cons of all these tests, they are highlighted here. The SPECT is supposed to be more sensitive than dobutamine stress echo. We are all aware of limitations of dobutamine stress echo. You may have window problem and you may have a host of other problems. However, it is an all or none phenomenon. It doesn't have a great grading between the different types of viabilities. Dobutamine stress echo can use both the thickness, because we do a resting echo, so it can use both the predictors of thickness as well as contractile reserve. Cardiac magnetic resonance imaging uses the wall thickness as the most important criteria, and the PET scan, as I said, uses the viability. As far as the magnetic resonance imaging is concerned, again, the cutoff here, because it is a more sensitive parameter, is not 6 millimeters, it is 5.5 millimeters. And again, this is being used in many areas, as we see here. So you can have scar present in typically in 1 to 25% of the cases. On the second part of the cartoon, it can be 25 to 50%, or it can be more than 50 to 75%, or more than 75%. So if it is more than 75%, the scarred area, then it is clearly sure that this is going to be a non-viable area. If it is less than 50%, we are pretty much sure that this is going to be viable. And if it is between 50 to 75%, we do contractile reserve testing, and then we are able to predict the viability. Now, the most often discussed trial for kicking viability, I would say, is the STITCH trial. Now, in the STITCH trial also, in the STITCH trial, what they had done is taken patients with left ventricular dysfunction, subjected them to medical therapy or coronary artery bypass grafting. In a percentage of people, about 40% of them, they actually did viability studies. And what they found was that whether you had a viable myocardium or not, there was no great difference in the results of doing CABG versus giving medical therapy. However, if you considered the viable segments and non-viable segments, there is a increase in the ejection fraction in those patients who have viable areas. However, again, as I said, the main point in the STITCH trial was that whether you did viability testing or not, this results of the CABG were not going to determine the ultimate outcome. However, there were many criticisms of this because the STITCH trial did not use MRI or PET. They used, SPECT or dobutamine stress imaging, which we all know are not the gold standards. Almost 40% of these patients were asymptomatic. The patients were never assessed for presence of ischemia. So it is quite possible that many patients had ischemia, and the LV volumes were not reported. However, this study did show, as I said, that if you have a viable area, your ejection fraction improves over a period of time. And there are subsequent studies which have shown that if you have a contractile reserve present, then that predicts the viability even better. This is a slightly older paper of 3,100 patients, which clearly showed that revascularizing, if we look on the top graph, if you revascularized the viable areas, then there was almost 80% decrease in the death rates. And it did not matter. It was statistically insignificant if you had medical treatment in these patients, which is given at the bottom. Now, further, it has been seen that if you consider viable segments, then the predicted death rates actually improve a lot. And on the right side are given the scatter bars, which shows that between the different modalities, what is the scatter? What are the 95% confidence intervals? So what we find is that for thallium and TSC, there is a very wide scatter. We can see the vertical bars are very big. But for FDG, the vertical bar is very small, which means that the results are more consistent and more accurate. So that continues to be the method of choice. There is also another paper which has looked whether the area of hibernating myocardium is important or not. And there was a PAR 2 trial of which this sub-analysis has been published. It has been seen that, if the viable area is more than 7%, then the primary outcome, which is a composite of cardiovascular death, MI, or heart failure, is less, and the number of patients surviving is also more. But there are 0 deaths in this. So I'll just be a very few minutes. So the 2021 AHA-ACC guidelines for coronary artery revascularization states it remains unclear whether viability studies should be used to inform clinical practice. And if they are used, it remains unclear which should be used. There is a paper published in Journal of Thoracic and Cardiovascular Surgery, which tells you that it is not just the amount of dysfunctional but viable myocardium, but also the left ventricular volume, which is important. So I've tried to draw this in this chart. The first one shows a normal sized heart. The heart then dilates and we have a mild to moderately dilated heart. Here, the viability is important. But if you have an extremely dilated heart, as it is given in the bottom, then the neurohumeral systems have already overtaken the benefit of viability. Whether you revascularize them or you don't revascularize them, you're not going to get benefit. So volume is also very important. Now, the topic was actually the algorithms. So this is the most simple algorithm. If you have coronary artery disease and the patient has angina, he doesn't fall into this viability testing. If he has dominantly dyspnea, you check for left ventricular function. If the left ventricular function is normal, even this person does not need any viability testing. If it is low ejection fraction, then you do the viability testing by using myocardial perfusion scans or PET or dobutamine stress echo or MRI. And at the bottom, it is given clearly that if your patient has hibernating myocardium or ischemic myocardium, that is the patient who's likely to benefit from revascularization. This is a more simplified, but in terms of acute MI, if you have a negative ischemia test, suppose you have not been able to revascularize the patient in the 36 or 48 hours window, which is a class 2A recommendation of the ESC, then you do that and the ischemia test is negative, go ahead and do the tests of viability. And if the myocardium is viable, then you consider revascularization, as I showed you in my case. So these are the last 2 slides. So the algorithm, which is given by the AHA scientific statement in 2020 on the imaging for myocardial viability. If your patient is suitable for revascularization, he goes to the second step. Then you assess whether there is presence of ischemia or not. If there is no ischemia, look at the extent of scar. If the scar is more than 50%, but less than 75%, you look at the contractile reserve. If the contractile reserve is present, then you revascularize the patient. If the contractile reserve is not present, then you leave the patient alone. And this is in subacute left ventricular dysfunction. If the patient is not suitable for revascularization, anyway, he's out. If he is suitable for revascularization, does he have any regional dysfunction? If he has regional dysfunction, test for ischemia. And if that is not present, test for metabolism or contractile reserve. And these are the patients who will benefit from revascularization. I thank you for your kind attention. A rather long talk, but I thought there was no other way to get about it.
So Thank you, Sandeep. I think we'll take the questions after the presentation of Dr. Soumitra Kumar. So please be seated here. So, our next presentation is by Dr. Soumitra Kumar. He'll tell us about the perspective with respect to the Revive BCS trial and STRITCH trial, which Sandeep has already touched.
Good morning, everybody. Thank you, chairpersons. Much of my job has been done by Professor Sandeep Bansal already. So I'll try and give you some crisp take-home message as how to go about, because most of the introductions about viability and associated trials have been spoken about by Dr. Bansal. So in the field of chronic coronary syndrome, these are some of the landmark trials that have happened in the new millennium. So in the first half, we had Courage, Bari 2D, STITCH. That is the subject of one of the subject of my talk. Then to follow it up, we had more defining trials like ischemia, FAME2, Orbita, and then we had various follow-up studies of STITCH, the long-term follow-ups, the STITCH viability studies, and so on, which were published later. And very recently, in 2022, we have had the revived BCI S2 trial and the FAME2 trial. And based on this, we have had some of the guidelines, the ESC, ESCTS guidelines on myocardial revascularization, ESC guidelines on chronic coronary syndrome, and ACC/AHA SKY guidelines, again on myocardial revascularization. So why are we talking about addressing this kind of contentious issue like viable myocardium and subjecting the patient to PCI? This is because of the tremendous advancement in the field of PCI that has taken place, starting from the study of coronary physiology, the FFR and its various other recent advancements, the IFR and so on. Then non-invasive imaging of the coronary arteries. Then, of course, the intravascular imaging, IVAS, OCT, and so on. So all these have contributed to tremendous improvement in PCI outcomes. So we have become more adventurous and now thinking of addressing very ischemic LV dysfunction. So this is the study that I'm going to present in little bit details and then talk about its perspective in view of the other trials, the Revive trial, presented in the last ESC 2022. What was the background? Whether revascularization by PCI can improve event-free survival and left ventricular function in patients with severe ischemic left ventricular systolic dysfunction as compared with optimal medical therapy, that is individually adjusted pharmacologic and device therapy for heart failure alone is unknown. So this was the design. LVEF was less than 35%. Viability was studied by all the modalities that Dr. Bansal has mentioned on CMR, DSE, SPECT, or PET. So it was a very state-of-the-art assessment of the viable myocardium. PCI feasible to lesions subtending more than equal to 4 dysfunctional but viable segments was carried out, and then the patients were randomized either to the state-of-the-art PCI or to optimal medical therapy. Optimal medical therapy was also state-of-the-art, as I'm going to show you. Echocardiography at 6 months and 12 months, and the clinical biochemical follow-ups were done at 6 months, 12 months, and 24 months. So it was not a very long follow-up. It was mostly 2 years or about so. But then there was no difference. We had 129 events in the PCI group, 37% of patients, and OMT 134 events, 38% of patients. So there was absolutely no difference in outcomes in the 2 arms, PCI versus OMT. And if you consider the subgroups, there are some interesting trends, but none were very definitive. You see younger patients tended to fare better with PCI. The BCI Jeopardy score, the more the score, the results were somewhat better with PCI. The worse the EF, again, little better with PCI, but not significant. Diabetes did not matter. Functional class, we did not have too many patients in NYHA 3-4, which was a fact, but then there was no difference. AF did not matter. Left main, very importantly, if you had left main, then doing PCI in such patients did have a poor result. So that is a point to be noted. And again, NT-proBNP values did not matter. So overall conclusion, among patients with severe ischemic LV systolic dysfunction who received OMT revascularization by PCI did not result in a lower incidence of death from any cause or hospitalization for heart failure. So these other, some of these trials have been mentioned by Dr. Bansal already, the HEART Part 2 and STITCH, and then the latest REVIVE BCI S2. So I mean, the primary outcomes were variable. So STITCH, revived, and HEART considered all-cause mortality, the hardest of endpoints. Part 2 had more of a composite outcome of CV death, MI, hospital admission due to cardiac cause. But REVIVE also considered hospitalization for heart failure because these patients had severe LV systolic dysfunction. There were several secondary outcomes. More so in the recent REVIVE change in NT-proBNP and unplanned revascularization were some of them. So, and then the quality of life scores, very important. That was also considered in REVIVE BCI S2. Inclusion criteria, all trials included very dysfunctional patients, LVEF in all were less than 35%. HEART insisted on more than equal to 5 viable segments. Then Part 2 had more a varied kind of inclusion criteria. STITCH did not depend on viability at all. So, I mean, whenever the coronary anatomy was suitable for revascularization, it was done. And REVIVE BCI S2, I mean, had a more stringent criteria, as I mentioned, that they needed to have 4 dysfunctional myocardial segments amenable to revascularization with PCI. And then people with acute coronary syndromes and other diseases needing surgery like aortic disease, cardiogenic shock, blah, 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 were excluded. I'm not going into that. So LVEF on an average was less than 30%. So very sick patients. As I said, of all these studies, the REVIVE BCI S2 had all the modalities that were studied. So it was a comprehensive viability study technique that was taken up in REVIVE BCI S2. So all these studies were more or less 5 years, but except REVIVE BCI S2 where it was I mean, even less than 2 years, you can see 41 months was the mean follow-up. So very short-term follow-up, and that is one of the drawbacks or limitations of the REVIVE BCIS trial. Now, when it comes to outcome, one thing is common, no significant benefit of revascularization of our OMT in the short-term period of 5 years. So STITCH only showed benefit when the 10-year follow-up results were considered. It showed a lower all-cause mortality than OMT. REVIVE BCI S2, again, overall same conclusions. But you see, as I'm going to show, somewhat better quality of life that is to be considered. But then whatever was there, quality of life improvement tended to disappear beyond 24 months of follow-up. So these are the trials side by side. And this again beautifully shows the impact of impact of viability-guided management on all-cause and cardiac mortality in RCTs of patients with ischemic cardiomyopathy. You see more or less neutral. I mean, it does not provide any benefit except for a subgroup of Part 2, which showed that study of viability does matter. But Part 2 overall was a very small trial. You can have a look at the number of patients that were included in this subgroup, very small subgroup. So this is a kind of a master slide. You see we have 3 variables: viability, prognosis, and functional recovery, that is improvement in LV function. So you see the dotted lines means conflicting data. The solid lines means well supported, and the red solid line means RCT demonstrates no association. So overall STITCH viability showed somewhat improvement in prognosis. But whenever revascularization was done, it was very, very doubtful. But overall, in the 10-year period, when CABG did show a reduction in all-cause mortality. And then overall viability and functional recovery, no. I mean, it does not. So functional recovery does not occur, but patients somehow at the end of 10 years with CABG in stitch trial live longer. Christmas trial, but was a medical, therapy trial with carvedilol. It did show that if there was viable segment, if you treat patients with carvedilol, patients can have an improvement in ejection fraction. In fact, beta blockers were the first group of drugs which showed an improvement in ejection fraction. And then functional improvement, better the ejection fraction, the better the prognosis is something that we all know. And then coming to the stitch viability sub-study 10-year outcome data. So it mostly banked on SPECT, and you see medical therapy alone and medical therapy plus CABG. When these groups are concerned, overall, in terms of demonstration of viability, no significant difference in the hazard ratio, but with viable myocardium, you can see that patients tended to do better with medical therapy plus CABG compared to medical therapy alone. So if you do revascularization with viable myocardium at the end of 10 years, you do benefit from CABG. So that was the outcome of the subgroup study, that is stitch viability sub-study. So a side-by-side comments, you see patients with stitch were treated at the state-of-the-art OMT at that point of time. So ACE inhibitors, beta blockers, and digitalis. Now, in revived BCIs, patients were treated with ARNI. You see 29%, almost 30% receives ARNI. MRAs, which were not used in stitch, were used, and beta blockers were, of course, used along with ACE inhibitors. So patients in revived received better treatment. Of course, SGLT2 were not used still in revived trial. Now, another drawback of revived when compared to stitch, limitation, is that less symptomatic patients were included in revived. And whereas in stitch trial, almost 43% of patients in stitch had CCS class 2 angina, such patients were not included in PCI BCS2. So this is the point to be noted. So unless you include patients with symptoms, how can you look for benefit? So that is one of the drawbacks of revived BCIS2. On the other hand, revived included older patients with a mean age of 70 and 69 years in PCI and OMT groups, whereas in stitch, there were younger patients, less than 60 years. So these are the points to be noted when we say that CABG is better and PCI is not. So although overall results lead to a conclusion of no added value of PCI over OMT in patients with coronary artery disease and reduced LVEF, there are at least 3 issues that may be taken into account when interpreting the revived trial. First of all, we have only studied till 41 months. So we really do not know what is going to happen at 5 years and 10 years. But already we know there were lesser incidents of VTVF terminated by ICD in the patients who had ICD. So, of course, we can, hope that these patients should tend to live longer with PCI when done properly. Then mirroring what we could see in the ischemia and FAME2 trial, the rate of spontaneous MI seems to be decreasing over time in patients who underwent PCI as opposed to OMT alone. So in addition, as expected, the rate of unplanned revascularization was reduced in the PCI arm. And third, as pointed out in an article in NEJM, a degree of selection bias could not be entirely ruled out, as some patients potentially profiting from revascularization may have been diverted towards surgery before being considered for trial enrollment. So these were another drawback. So in addition, 2/3 of patients had no angina on baseline, and the decision to revascularize was preconceived by the existence of myocardial viability, which in the stitch trial did not have an impact on the effect of surgical revascularization and mortality. So these are the modalities, the types of kind of ischemic LV that we know. So stunning, early hibernation, advanced hibernation, and infarction. And you know how it matters in terms of contractile reserve, glucose metabolism, extracellular volume, and so on. And these are the various methods, again, highlighted by Dr. Bansal. So SPECT, targeting membrane integrity, CMR, extracellular volume, DAC on contractile reserve, and PET on glucose metabolism. So the conclusion, which also Dr. Bansal has highlighted, viable myocardium should not be considered as a single entity, but as a spectrum, including jeopardized, stunned, early hibernation, and advanced hibernation, the revascularization of which may yield different pathophysiological benefits. For patients with ischemic LV dysfunction, the question is not whether they have viable myocardium, but how much they have of each type, where it is, whether it is likely to recover, and how long this may take. So these are the crucial questions to be asked. So this is a master algorithm that I would like to present to the audience. So managing patients with ischemic cardiomyopathy, anginal patients, if no, look for significant myocardial hibernating myocardium, at least more than 7%, studied by PET or CMR. If yes, go straight for CABG on top of OMT to improve prognosis. If not, go for a heart team evaluation, consider CABG. If low surgical risk, Euroscore 2 less than 4%, consider PCI in selected cases according to syntax score. If anginal symptoms are there and there is significant inducible ischemia more than 15% of the LV, yes, again straight away go for CABG on top of OMT. If no, again heart team evaluation, CABG for low surgical risk, Euroscore 2 less than 4%, PCI in case of refractory symptoms if CABG is not indicated or refused. So the concluding remarks, until newer and more relevant evidence emerges, surgical revascularization, when technically feasible, after carefully weighing of the perioperative risk, would appear to be the best option for selected patients with ischemic cardiomyopathy. Such an approach also has been reported to be cost-effective over OMT. Viability or ischemia testing appears not to be mandatory based on current evidence. Documentation of viability today possible at its best with CMRI or PET would, please note, would still appear, however, a logical step, no matter if not based on strict evidence, but with the aim of tilting the balance in favor of surgery in cases where perioperative risk makes decision particularly difficult. And then conversely, the practical impact of ischemia testing on clinical decision-making, particularly in the absence of ischemic symptoms, would appear less robust, although in recent retrospective evidence in patients not selected for LV ejection fraction suggests a possible benefit of ischemia-guided revascularization in the presence of a very severe ischemic burden that is more than 15% of LV myocardial, as I showed, based on SPECT. Such data, of course, need further confirmation in dedicated RCTs. So considering the recent results of revived BCIS2 trial, indications to PCI in patients with ischemic cardiomyopathy would remain limited to patients in whom ischemia-related symptoms such as angina are refractory to OMT and predominant over heart failure-related symptoms. Thank you very much for your patient hearing.
Yeah, thank you, Dr. Habaj. Sandeep, just I wanted to know what is the difference between viability and ischemia? How do you interpret the report?
So ischemia typically means that we all know of ischemic cascade. The ischemic cascade starts from a problem in the perfusion. Then there is a problem in the diastolic function of the heart. Then there is a problem in systolic function in the form of regional wall motion abnormalities. And then there is ECG changes. So we can detect the ischemia at any stage. We can detect it with, as I said, with the SPECT or with dobutamine stress echo or with treadmill testing. There will now, what is the difference between viable? Viable basically means that if you do a treadmill test in these patients, this may still be negative because these patients may not show any ischemia. On the other hand, they will show, this particular thing actually arises only in a chronic hibernating myocardium. You may not have ischemia, but there will be a lot of patients who may still have a living myocardium, which will improve with revascularization. Ischemia essentially means that there is a difference between stress and rest. That's it. Whereas viability means that there may be no improvement on stress, but the heart may still have area which, if reperfused, will improve in function.
And second question, Dr. Kumar, we see a lot of LV dysfunction. So do you suggest all patients of LV dysfunction should undergo angiogram? Because then only this question will, because if you see the revive, it looks to me it's a heart failure trial, almost semi-symptomatic, asymptomatic EF28. How it was planned to do angiogram and find out he had a 2 vessel.
Yeah, it is something that we do like in motor neuron disease to exclude the spinal compression. Okay. So, I mean, knowing the etiopathogenesis of LV dysfunction is almost mandatory. For that, angiogram is definitely required. Now, next issue comes whether we are going to do something based on the angiogram report, whether it can improve the LV function. So therein comes the question of viability and ischemia. But then, as you said, in younger patients with not so dilated LV, subjecting them to CABG, unless there are other comorbidities, may still ill benefit. But in older patients, where you are not sure, demonstration of viability, I still think holds good. If patients have anginal symptoms, decision-making becomes much easier. But for asymptomatic patients, decision-making is more difficult. So,
Yeah, Dr. Sahu. Yeah. Yeah, it's on.
The
Yeah.
question of viability we ask ourselves, or we ask when the patient presents with a severe LV dysfunction, presents with a heart failure, and there is no history of angina. It may be comorbid diabetes or other comorbidity. Patient has no angina, we go for a angiography in those cases. So with heart failure, when there is no symptom of ischemia, or cannot go for a reversible ischemia test like suggested, either TMT or reversible myocardial echo or myocardial perfusion imaging, then we go for a viability study. So my question is, when patient with the ischemic cardiomyopathy presents, and we should go for angiography whether we can improve the patient, the either dilated or ischemic cardiomyopathy, we go for angiography and found there is a block. But unless the myocardium is viable, he won't get benefit. So we test for viability. So which viability study, if all of the viability models are available, which test will do? Because in street trial, as you were mentioning, they had did not have the SPECT or bed study, other things they did not do viability study in all cases. So which viability study will suggest in this case?
See, as I said, the gold standard still continues to be an FDG PET, fluorinated deoxyglucose PET, because the change in metabolism of a hibernating myocardium is a very important feature. Actually, this is a gray area. As I showed I tried to show that it is not just viability that matters. What also matters is what is your ventricular size. If the heart is ballooned out, it is. I was talking to Professor Bax, Jeroen Bax, in one of the meetings in Bombay, and they said that if the left ventricle is dilated beyond 7 centimeters, if my patient's LVID-D is more than 7 centimeters, or if my patient's LVID-S is more than 5.8 centimeters, 58 millimeters, then there is not going to be any benefit of any intervention, because by this time the neurohumeral activation has become so strong that even if you revascularize, there is not going to be much benefit. So it is not just viability, it is the degree of dilatation, it is the duration. Dr. Soumitra repeatedly highlighted that, and I also tried to do that in my first few slides. If my patient's index event has happened a couple of months ago, 3 months or 4 months or 6 months ago, then the remodeling has not taken to an extent that revascularization will not benefit these people. When you're not able to make out, you look at patient's contractile reserve. If the patient, because that is also one of the methods to judge the viability. So viability it's got different arms, and one has to take a collective judgment based on the volume, based on the presence of contractile reserve, based on the FDG PET, and even CMR. But- Yes, because if it is not showing increase in contractile reserve, as I said, one of the problems with the nuclear scans is that they are continuous. They are on a sliding scale. They do say, if that is why they say if it is a more than 50% uptake improvement, that is important. But generally, you will find in routine viability testing, they will just say that this is a viable area. And then we have also, he also stressed on that, and we have all learned in 1993, when I was actually preparing for my DM, the American College of Cardiology statement used to say that if the ejection fraction is less than 40% and you have more than 20% viable area, then CABG helps. It helps in improvement of mortality. But slowly and steadily, as angioplasty has overtaken, the percentage of viable myocardium has been decreasing. From 20, it came to 15, which Soumitra also said is very large area, and it is considered now. It used to be 20%. So you are becoming more and more non-selective. You keep on decreasing. This is what happened in ischemia trial. They started with a 15% cutoff, then they came to 10, and then they came to 7. So we are like wanting more and more. If you follow stricter criteria, you will show improvement. But it is because we are making our criteria less and less. That is why the statistically significant improvement is less. And the most important underlying fact is what Dr. Soumitra also showed in one of his last slides. We must realize that medical therapy has improved tremendously. When the previous trials were done, there were no drugs to treat. Now you have ARNI, you have the 4 pillars of heart failure therapy. They are beneficial across the board, whether it is ischemic or non-ischemic.
When
Live case actually at 11:20. So
Can I ask one question?
yeah, last 1 minute. Yeah,
Okay.
we have to go live.
What do you do in your clinical practice?
For viability. Yeah,
Yeah,
Soumitra.
related to viability, acute and in chronic situations.
So in your institution, what is available? So most of the time it is, if you have oncology, you have a PET inside your hospital, you get a PET scan done. And if you are not, then next is MRI. So nowadays, hardly we are doing a technetium or thallium scanning. Either FDG scan, which is a lot of ifs and buts of carbohydrate of so many drugs. MRI problem is interpretation problem. So people are still learning on MRI. So you make a use of probably both. I'll use PET first because we'll assess other etiology, infiltrative, sarcoid, myocarditis, other things you can rule out and then do a selective MR.
If a patient has obstructed LAD, MI 3 days duration, what do you do?
That's different. If it's a flowing artery, probably I'll go and fix it. If it is occluded, just put him on medical management and assess viability. Okay, so we close the session and thank both the speakers and my co-chair.